चलिए स्टार्ट करते हैं। क्वेश्चन नंबर 1 GIT get through. ठीक है, क्वेश्चन नंबर 1 woman with multi-system disorder brain swallow show the dilated esophagus with a pericardium of the lower third of the esophagus, a patulous lower esophageal sphincter and gastroesophageal reflux. Which organ system most likely to be affected? Skin. ठीक है, ये diagnosis है scleroderma और जो है ये भी कह रहा है कि on barium swallow diagnosis scleroderma on barium swallow which is dilated esophagus with aperture of the lower third of the esophagus and a patulous lower esophageal sphincter and gastroesophageal reflux. But diagnosis is scleroderma. Dilated upper esophagus with aperture of the lower two-thirds esophagus. Another image of scleroderma. Also the paralytic ileus. This we will discuss afterwards. This is also scleroderma and the bowel loops. In this, there is a multiple enfoldings of the bowel loops involved. We will discuss this afterwards. You have the scleroderma, this one, patulous esophagus on CT scan. Okay, next image. You have scleroderma. Brain follow through of the small bowel demonstrates generalized bowel dilatation with a closely approximated valvular conjunctivities, which are normal thickness. Generalized bowel dilatation with closely approximated valvular conjunctivities, which are normal thickness despite the dilatation of the bowel lumen. No strictures, stenosis, or masses are visible and mucosa is otherwise normal. They also same scleroderma, but they are saying it in magnified view. We must say that there is generalized bowel dilatation with closely approximated valvular conjunctivities, which are of normal thickness. Next question. Question number 2. CT scan demonstrates marked circumferential bowel wall thickening in one of the entire colon with minimal pericolonic stranding and a small amount of ascites, most likely diagnosed pseudomembranous colitis. Because its full colon wall is involved, is thickened and ascites. In ischemic colitis, there is going to be a history of cerebrovascular accident. In ischemic colitis scenario, there will be a history of cerebrovascular accident or cardiac disease. And this also, they are saying that this is pseudomembranous colitis. This one, this is pseudomembranous colitis. This is ischemic colitis. Now we'll list pseudomembranous colitis. This is called there's CT scan demonstrates marked circumferential bowel wall thickening involving the entire colon, and then there may be ascites, minimal ascites, and pericolonic fat stranding. These are also pseudomembranous colitis. Okay, accordion sign इसको कहते हैं. You call it accordion sign and pseudomembranous colitis. This is radiation colitis, thickened bowel wall loop after radiation. Question number 3. Most accurate imaging modality for local staging of esophageal cancer, esophageal endoscopic ultrasound. For esophageal cancer staging, we do endoscopic ultrasound for local staging. Question number 4. Which radiological field would favor diagnosis of malignant rather than benign gastric ulcer crater confined within the gastric contour? The benign gastric ulcer features malignant gastric ulcer features. The benign gastric ulcer features we read first. Okay, favorite diagnosis. First is that malignant gastric ulcer mucosal folds are effacing mucosal folds. The site is in the greater curvature. Margin is irregular margin. Floor shows necrotic slough in the floor, and it shows filling of the contrast, pooling of contrast. Edges are everted edges. Surrounding area shows nodules, ulcers, and irregularity. And size and extent is large and deep. Like for example, crater size. So in the MCQs it says that with diagnosis favors malignant ulcer crater confined within the gastric contour. Benign gastric ulcer folds are converging towards the converging folds, and then margins are irregular. Floor granulation tissue floor, edges not everted, punch out, and surrounding area is normal, and size and extent small, deep, or up to muscle layer, and size and extent gastric malignant ulcer large and deep. Question number 5. Small bowel follow through to dilatation of the proximal small bowel with population and segmentation of the perineum column, most likely diagnosed celiac disease. Dilatation of the proximal small bowel with population and segmentation of the perineum column, most likely diagnosed celiac disease. When an MCQ comes population, then diagnosis of celiac disease. The diagnosis of celiac disease, and there's common jejunal loops with loss of mucosal folds and normal caliber ileal loops. Okay. Celiac disease again, ileocecal tuberculosis, and this celiac disease, celiac disease, celiac disease. So on small bowel follow through, there's flocculation, dilatation of proximal small bowel, and flocculation and segmentation of the barium column. There look, you can see segmentation of the barium column and the dilatation of proximal colon and segmentation of the barium colon. So diagnosis celiac disease. Question number 6. Ultrasound shows liver is diffuse increased equidensity. The detonation of the ultrasound beam and poor visualization of intrahepatic architecture. We have found imaging period is most likely loss of liver signal intensity on autophagic parent echo MR images. We diagnose as fatty liver. So on ultrasound, there's liver of diffuse increased equidensity with detonation of ultrasound beam and poorly visualization of intrahepatic architecture. Diagnose as fatty liver, which imaging period most likely loss of liver signal on autophagic parent echo MR images. It shows fatty liver. Question number 7. Conventional defibrilography. For introduction of barium patient into the rectum, in which position should the patient be placed for imaging? Sitting. Okay, so this is defibrillography instrument, so the patient sits on this. Now, these are also images of proctography or defibrillography. Just for identification, the barium, okay. So important is post evacuation, pre-evacuation, feeding, defecating proctography. These are defecating proctography, and then rectal ultrasound. So these are okay. So defecating proctography. So in conventional defibrilography, following introduction of pace, patient should be in sitting position. Question number 8. CT scan shows herniated loop of small bowel is seen emerging inferior lateral to the left pubic tubercle. What is most likely cause for the small bowel obstruction in this patient? Femoral hernia. Because hernia is also an important topic. Herniated loop of small bowel is seen emerging inferior lateral to lateral pubic tubercle. Inguinal hernia, femoral hernia, operator hernia. Can you see this in this inguinal canal? It is going through the inguinal canal hernia, right inguinal canal, so the inguinal hernia. This goes to the femoral canal, so femoral hernia, right femoral. This goes to the operator foramen, to operator hernia. Similarly, the inguinal hernia, the femoral hernia. This is operator hernia, normal size operator hernia. It says here femoral. A herniated small bowel loop is seen emerging inferior lateral to the left pubic tubercle, or here right pubic tubercle. Most likely causes small bowel obstruction, femoral hernia. Next image. Okay, this is strangulated hernia. Small bowel obstruction due to strangulated hernia and anterior abdominal wall. Question number 9. CT scan of the abdomen shows 2.5 cm old lesion with a attenuation value of -6 GHU. Hepatic and sigmoid colon with surrounding inflammatory changes. Most likely diagnosis is like appendicitis. When it is -6 Hounsfield unit, it means it's fatty. So it diagnosed like appendicitis. Now let's see image of it. Tuberculosis, ileal stricture, like appendicitis. The like appendicitis over here. This will be like fatty like ecotexture, so -6 GHU. How to describe it? 2.5 cm oval lesion with attenuation value of -6 GHU, about -6 GHU. Hepatic the sigmoid colon, or here will be the descending colon, and then with surrounding inflammatory changes, then like appendicitis. Oval lesion with attenuation, fatty heterogeneation, hepatic the colon, and with surrounding inflammatory changes. Diagnosed epiplaque appendicitis. Similarly over here, an oval lesion with fatty attenuation, hepatic the colon, with surrounding inflammatory changes. diagnosed epiploic appendicitis. Again, same on here, an old lesion with fatty urination, aorta in the colon with surrounding inflammatory changes, diagnosed epiploic appendicitis. There are serous and mucinous carcinoma appendix. Okay, question number 10. A CT scan of the abdomen shows incidental finding of well-defined 5 cm mass in the head of the pancreas is noted. It has mean attenuation value of 5 HU and contains multiple tiny cysts with a central nidus of calcification. Most likely diagnosed serous cyst adenoma. Tiny cyst with nidus of calcification is seen as serous adenoma. Multiple cysts with central nidus of calcification, serous adenoma. Multiple cysts with nidus of calcification, serous adenoma. Or central scar, serous adenoma. Now, mucinous adenoma is large and solitary lesions, cysts in head of pancreas. Serous, okay, just see the mnemonic. S is equal to serous. Is small. Multiple. Sir equal to head of pancreas. And also is equal to scar, central scar. Correct? And for mucinous, M mucinous, single, large, no scar, and body and tail. Correct? Also, serous has bunch of grape appearance. So bunch of grape appearance, a lesion seen in the head of pancreas with central scar. Your central nidus of calcification, diagnosed serous adenoma. Cystadenoma. Mucinous cystadenoma. Serous cystadenoma, bunch of grape appearance. 12. Which venous structure divides the liver into right and left hepatic lobes? Right hepatic lobe, left hepatic lobe. Middle hepatic vein divides liver into right and left hepatic lobes. Question number 12. What is the primary imaging investigation for staging of colon cancer diagnosed with colonoscopy? CT of the thorax, abdomen, and pelvis. These colon cancers can spread to the thorax, abdomen, or pelvis. The primary imaging investigation for staging colon cancer is CT scan, thorax, abdomen, and pelvis. Question number 13. A 65-year-old man with pain and tenderness over left lower quadrant. CT scan. The superior mesenteric vein is dilated with thin rim of enhancement on a central area of low density. What is the most likely initial pathology demonstrated on the CT? Sigmoid diverticulitis. What is the diagnosis? Inferior mesenteric vein thrombosis. Okay, the patient pain tenderness left lower quadrant and inferior mesenteric vein is dilated with a thin rim of enhanced effacement. So simple. The inferior mesenteric vein is dilated with thin rim of enhancement on a central area below. So low equidensity, thrombus, and enhancement surrounding it. So most likely in pathology. So this inferior mesenteric vein thrombosis is associated with sigmoid diverticulitis. So inferior mesenteric vein thrombosis is associated with sigmoid diverticulitis. Question number 14. CT scan shows loculated collections of very low attenuation fluid in the peritoneal cavity, contains scattered curvilinear calcification, and a scallop contour of the liver, most likely diagnosed pseudomyxoma peritonei.